It looks like, there we go. All right, wonderful. And so we have, and so you are consenting, hopefully all of you, to be in this meeting that's being recorded. And we will then post it on our website, our Cheatham County Cancer Survivors Alliance website, so that people can see it, even if they couldn't join us tonight. So I'm going to be going quickly over some aspects of the Alliance. Some of you will have heard some of this before. And then we will have two presentations. And before my presentation about some of the things the Alliance does, Monica, I think you have a pre-program survey to put up for a few minutes. It's pretty short, and it's a way for us to gauge how clear we are in the information that we present. So Monica, if you would start that survey, please, that would let us get that done and move on. Okay, thank you very much. And so you can see fairly quickly, we want to know who's here. And some information that we ask for to help us meet the needs of cancer survivors in this county. And it looks like you have to answer every question in order to be able to submit your answers. So we'll take one more minute for that. And I'm going to then that's our survey question. Give a little bit of a background about the Alliance. So again, some of you have heard before that the Centers for Disease Control and Prevention provides funding to the Tennessee Department of Health for a wide variety of programs. And some of that money is used with the Cancer Coalition to identify the problems, the burdens of cancer in Tennessee. And using that information, the Cheatham County Community Enhancement Coalition submitted a request for funding last December to address the burden of cancer survivorship, that we would like to have better outcomes for cancer survivors in our county, health outcomes and quality of life outcomes. And so the funding was provided for the Cheatham County Cancer Survivors Alliance, which began last summer. And we have a web page now, and you can go to the cheathamcoalition.org webpage, and you will see along the top tabs there, the Cancer Alliance has its own page. And we encourage people to look at that page. It gets updated very often, has information about lots of different resources and services, ways for people to volunteer to join us, and a very important set of links to get to some requests we have for people. So we are offering community education programs, and we've had a couple, and these are fairly short, I would say, 25 to 30 minutes long. A member of our team will either come in person or we can do it virtually to present a PowerPoint slide program about cancer survivorship. There's really quite a bit known about how to improve quality of life. I'm so sorry. I forgot we have another questionnaire here. Thank you, Monica. This is important. We'll do this before I continue. Okay, this is very short. So if people would please answer the questions. I think we have question 5, looks like it's repeated. In a way, 6 is, I don't know what happened with 6. Okay. All right. Yes, I'm sorry, Monica, I forgot that there was a second survey. So the first survey is really to find out who's in the room, and the second survey is a set of pre-questions to see how clearly we present information. So this is our Cheatham County Community Enhancement Coalition website. And as I mentioned, there is a new page with lots of information for cancer survivors and caregivers and allies. Allies are people who just want to help improve quality of life and care for people who've been diagnosed with cancer in Cheatham County. And for the sake of our project, the Cancer Survivors Alliance, we define survivors as anybody who has been diagnosed with cancer. And you'll find different people having different definitions of the term, but just to kind of keep us all on the same page for the purposes of this alliance, that's our definition. So it can be someone who is still in treatment, or someone who is off treatment recently, or someone who's been off treatment for a long time. Of course, people get to choose their own name for who they are, their own identity. So some people might not want that term, and we would certainly respect that, but that's how we generally mean the term. So, getting my slide to advance here. It seems to be a little bit obstinate. Okay, so I was mentioning the community education programs that are free. People can contact our coalition office and say you'd like to have a program presented to any kind of a community organization, a group of neighbors who want to come together. We would be happy to present this set of information for people who are interested in helping to improve quality of life and outcomes for cancer survivors. So we also talk in this meeting, in this presentation, about other services that we offer. And one of those is a 6-week educational support group called Cancer Thriving and Surviving. It's a 6-week course, it's free. People who are participants in this class get a really good book called Living Well with Chronic Conditions. And we can do this virtually. Eventually, we may be able to do it in person again, but we would really like to be able to get 8 or more people together who can participate in this activity with us. It's a program that's been around for almost 20 years. It's offered all over the world because it has turned out to be a very effective program for helping people to feel more empowered to manage their lives, how to talk to their healthcare team, information about nutrition and sleep and stress management. So it's chock full of information, and many people find that it is really helpful to talk to other cancer survivors and other caregivers. And then finally, as part of an overview of what we're doing, we have a survey that we would really like to help disseminate around the county. We're very interested in getting feedback from cancer survivors and caregivers about what we need in Cheatham County. We have data that indicates that Cheatham County is kind of near the bottom of counties in the state in terms of health outcomes for cancer survivors. We'd really like to change that, but we need information from people who live here to tell us what kinds of problems they've had, what kinds of services they want. And that's what this survey is about. So you see a link here. You can also go to our webpage, and there is another link you can click on there. And if anybody is interested in completing the survey in a paper form, they can just contact the coalition office and say, please mail me a paper version of the survey. All right, now we get to the more exciting part of the program, and that is our featured speakers. And I am so pleased to be able to introduce to you first Joyce Bell. And I asked Joyce for some information that she would like me to present as I introduce her. And so she identifies herself as a transplanted Texan. She told me that she taught school in Tennessee for 25 years. First, she was in Ashland City Elementary School, and then East Cheatham Elementary School. She retired in 2007. She's still very active in the community. She is a mother, a grandmother, a great-grandmother, and she says she is thankful to be alive and well and to enjoy her family. And she said she considers every day to be a gift from God. And so we are going to, I'm going to stop sharing my screen so that we can bring up Joyce's picture. Let me find out where you are, Joyce. And I recommend that we put you on speaker view. I'm looking to see to make sure that Joyce is here. Let me see if I have any messages indicating to me that Joyce is having problems getting in. It doesn't look like she's on the call right now. Yeah, I see that Claudette is having a problem. Claudette Pfizer is, okay. Monica, could you check to see if Joyce is in the waiting room? Because she says they're getting a message that the meeting has not begun. I can suggest that they log out and log back in.
Rebecca,
Monica,
it's Amber.
do you
There's
see
no
them
one
in the waiting room? Okay.
Rebecca.
Well, yes.
I was just saying, I can also see the waiting room. There's
Amber?
no one in the waiting room.
Okay. I'm so sorry that this had a problem. She's having a problem. I am going to forward the link that you just sent me, Amber, about half an hour ago to them. But she said that they haven't been able to get in. So we'll take a minute. Okay. Well, not a problem that I anticipated, but that's not unusual for there to be problems that we don't anticipate. So let's see here where I have Joyce's email address. Okay. So we'll get her here in a minute. Okay. So it's possible that they didn't have an accurate link, but Claudette said that they are logging out and logging back in, and hopefully we'll have them here in a minute. So let me just give a minute to see if anybody has any questions about what I've gone over so far while we're waiting for Joyce to join us. I know that some of you have been in our town halls before, so I think most of what I presented so far is similar to what we presented in December, with the exception that our community education programs are now happening. They weren't happening yet back in December, so that's been exciting. And we have set up a number that will be occurring later this month and in April, and we are happy to have people contact us and suggest places where we can present. Let's see. No sign yet. Let me think. I know, Liz, you are ready to go and probably will have more to say than we will have time for you to say this evening. We did give you more time on the agenda this evening than we did back in December because there were a number of questions for you and because you were offering something that I think a lot of people would like to have information about how to keep track of your own history. And I think that's really valuable information for people to have. So I am thinking, Amber, any sign of anybody else logging in? Not sure what the problem is. I had a lovely conversation with Joyce, who
Yeah, I'm not
was
sure why
suggested by, was it?
I'm not sure why it's not working because it worked for,
Yeah, for everyone else.
yeah, I'm not sure what the problem is.
Yeah, and I did just send the link again to Joyce. Now they may be on Claudette's desktop, so let me let Claudette know. Okay. All right. So in prelude to Joyce being able to join us, I can just let you know that she has had several different kinds of cancer. And so it's, been, I'm sure, very trying for her and her family. And so she comes to us with a variety of experiences from different episodes in her life, and very graciously offered to provide some information as well as some encouragement based on the kinds of experiences that she's had. So I'm hopeful that she will be able to join us soon, and we will be able to, you will be able to hear from her some of the points that she made when she and I first talked about how she has managed those situations and has maintained a quality of life that she finds very satisfying. So still no signs of what's going on with her. Liz, perhaps you, I don't really want to know how it's going to be for you, but maybe you could just begin a little bit introducing yourself, and then when Joyce joins us, we could shift back to her. Would you be willing to do that, Liz? I know it's going to be a bit of a disjoint, but I thought that would be nice. So let me just introduce Liz very briefly for those of you who don't know her. And Liz is an advanced practice registered nurse. That's what the APRN stands for. And she is at the Vanderbilt Survivorship Clinic. And she told me that she has been at Vanderbilt for 25 years. And she has been part of the survivorship team for the past 2 years, or it might be getting close to 3. So we'll watch for when Joyce comes, but in the meantime, Liz, I think I'd rather give you a chance to talk than for me to talk. Please.
All right, can you hear me? Am I on?
I hear you fine.
Okay, perfect. All right. Anyway, thanks for having me back. I really enjoyed our last visit at the last town hall. Just to tell you a little bit about myself, as Rebecca said, I am a nurse practitioner and I manage the adult cancer survivorship clinic at Vanderbilt. We also have a pediatric cancer survivorship clinic, and there's a pediatric nurse practitioner named Shauna Stanley that manages that clinic. And I have been at Vanderbilt 25 years. I'm very excited to get my rocking chair this year, but I'm afraid I'm going to be rocking it still at Vanderbilt for several years till I actually retire. But anyway, when we met back in December, Rebecca had asked me to present, and the first thought I did was I would present what I present for most community-based organizations. They want to know about what we do at the survivorship clinic at Vanderbilt. And she mentioned to me, she said, well, that's great, but I really didn't want you to focus too much on Vanderbilt. And I thought, well, what should I do? And I thought, well, maybe this shouldn't be about what I do, but what you can do. So that's kind of changed our focus in on my last presentation. And so I wanted to really kind of show you what I do and how we can translate it into what you can do with your records. But at the center of survivorship, the survivorship clinic of survivorship care is what we call our treatment summary or care plan. It's often described as a roadmap. But I like to think of your first trip into our clinic as you've come to a fork in the road and you've got decisions on where to go. You can either go towards wellness or you can go in actually in a number of directions. So that's what our care plan likes to, or we try to do with that. And our focus, of course, is wellness, but also we are a bridge between oncology care, primary care, and we are extenders of oncology care. We're one of the support organizations at Vanderbilt for our oncologists. The oncologists focus on the diagnosis and the treatment of cancer, but with somewhere, it's been estimated anywhere from 16 to 22 million Americans are living 5 years after their cancer treatment. That's a large number of people. And it's also estimated somewhere that 90+% will have long-term effects. So that's where we come into play. So we're there to help you, to help physicians in managing long-term effects. So I'm just going to focus on the care plans tonight. So if I can, I'd like to share my screen. See if I can, okay, can you see this? All right.
Yes, we can.
Okay, so basically what I did is I tried to put a template together for you and things that I think are important. I often will get patients come to me for their first care plan or their first survivorship meeting, and they may have 2 folders full of information. And then they're fine because they've asked for all of their medical records, and many of them say, well, I've been wanting to put this into a document, and then they're surprised that I've already done that. So I wanted to show you the document this is just kind of a sample of what I put together for our patients when they come to the survivorship clinic. But you can see this is the kind of information that we put together, and we share this not just with the patient, but this is also shared with the primary care and their oncology team. So basically the things that we want to cover are where you had your treatment. And while in this case, it's at Vanderbilt, that also may be Centennial, it may be Baptist, it may be MD Anderson or Northwestern. So we try to bring all those different places into one area so that we know how to contact them, their primary care knows, and the patient knows. And over time, we're going to forget who our care team is. So we bring that into place too. And again, when primary care has questions, this document can serve as a way that they can look back and see who they need to contact for more information. So at the heart of any care team is our primary care provider. So this happens in this example, Catherine Lynn, who is one of our long-term PCPs. Ben Ho Park is one of our medical oncologists. And you can see that I've just named various members of the team. And I did this very simply, but in the case where these are often usually, I will also have telephone number and fax numbers to make it more convenient. Then I put in the cancer diagnosis, staging, involved fields. And this is just trying to make some sense out of what your pathology report says, what your diagnosis is, what the stage is. That's what should be stage there. Stage 1A. and bilateral breast cancer. And then these are very important. I've tried to make this pretty specific because, as I said in our last meeting, it's very, this can tell us a lot about how to treat you in the future. For example, and I'm using breast cancer because this is a population I work with a lot. If a patient's tumor expresses estrogen, that's going to affect our decision making down the road and how she can be treated with estrogen replacement therapy or other type of questions that can be answered. Or in this case, BRCA2 or BRCA1 positive. This one should be 2, although it can be 1 or 2. In this example, it should have been 2. But when we see BRCA2, we know that this can put the patient at risk for other cancers. Then I like to take the genetic testing that's been done and put it in, the results of that in, and that can be done very quickly by taking the name and the date, the genes tested, and then the results. Very, very quickly done. The date they were diagnosed, that was your first day that you had your first biopsy. Into treatment, that's when you finished your chemotherapy, radiation, or endotherapy. Date of diagnosis, because that plays into your prognosis as well. And then family history. And then your cancer treatment history. So let me see if I can go over here. In this case, I'm looking at a chemotherapy regimen, and I give it its name when we call that dose dense AC, or that's a adriamycin is cyclophosphamide with Taxol in this case. Now I go through your medical records and I come up with the total doses received. Like Cytoxin in this therapy was 600 milligrams per meter square through the 4 cycles that she received. Doxorubicin was 200, excuse me, it should have been, I should say 2,400 milligrams per meter square. That's a total dose. And then on the doxorubicin, that's 200 milligrams per meter square. And it's important for us to know some of these cumulative doses like anthracyclines. Then hormonal therapy, that would be like letrozole, tamoxifen, other like estrogen therapy, or endocrine therapies, aromatase inhibitors. And then I take all of those operative reports that they have in those files, and I've probably done that before they bring their files to me, but then I list those surgeries. Now, I didn't take the time on this one because this is just a sample, but I'll also typically not just the date and the name of the surgery, but I'll also put the surgeon in there. Now, in this case, this patient that I was using as an example did not receive radiation therapy, but that's also something important to know. And I look at their endotherapy report from radiation oncology and bring in the start date, the end date, what field was involved, and that's significant. Usually, like I would put left breast here, the dose they received. And then if there's a boost to the tumor bed, dose received, total dose. And then I've already reviewed records.
Liz?
Yeah.
Liz?
Yes.
Liz, let me just ask you, when I don't want to stop you mid-paragraph, but I see that Joyce has joined us. I'm so glad to see you, Joyce. And so Liz, when you get to a point where you feel comfortable taking a break,
That's fine. Joyce, just jump on
like
right in there.
That
no, that's fine. Just jump on in there. But everybody has to remember what I've already talked about it.
Yes.
I'm going to turn on. I'm going to mute myself.
Muted.
I'm going to mute it.
All right, Joyce. Joyce, you need to unmute yourself. And I did give a bit of an introduction, but we cannot hear you, Joyce. Okay. I'm going to tell your mom is in.
Unmute. Okay. Okay, can you hear me?
So there we go. Joyce.
Can you see me?
Welcome very much. Liz, Liz, would you please stop sharing your screen so that we can make Joyce, we can put her in speaker view. And then everybody, if you know how to put speaker view, it's in the upper right-hand corner. And then Joyce, I did introduce you briefly before you came with your history from Texas and your history of teaching and your gratitude for every day as a gift from God. So please take it away. I'm so glad you were persistent and you are here with us now.
Okay, this is scary. Are you still? Is it still there? Hello, you still there? I can't hear.
Yes, you are doing fine. You are fine. I'm going to turn off my mic.
Okay.
But I'll be still watching.
Okay. In the early 70s, I experienced my first bouts with cancer. 5 malignant tumors were removed from my bladder and then reoccurred over a period of several years. Then in May 1996, I detected a lump in one breast. It was Friday before Memorial Day weekend, and no one, not even the Women's Pavilion at Baptist Hospital or the Breast Center at Vanderbilt, could see me until the next week. I was panicked. In desperation, I contacted a rural doctor whose office was in a converted house in Joelton. He could see me immediately, did an exam in his office, and his wife arranged for x-rays that very afternoon. I was sent with my x-rays to Dr. Stephen Leach at Vanderbilt and all of this in just a matter of a few hours. Dr. Leach did a biopsy soon after, and the next week, in the kindest, most caring way he could use, he delivered the shocking news to my husband and me. He gave us a few minutes alone to process, and then he came back in the room and we got down to business. My niece worked with Dr. Charles Balch, one of the leading breast cancer experts at MD Anderson in Houston. She advised me to have Dr. Leach forward all my records and information to him. Dr. Leach was very willing to do that. Word came back that Dr. Leach had trained under Dr. Balch, and everything Dr. Leach was doing was exactly what Dr. Balch would have recommended. The result was I had a mastectomy. I had read and heard horror stories about the gaping raw wounds, the ugliness of it all. Dr. Leach calmed my fears and answered every question, and there were many, and set my mind somewhat at ease. He then set up an appointment with Dr. David Johnson, oncologist, who undoubtedly was the kindest, most caring doctor I've ever met. He had experienced cancer himself, the pain, depression, all that sometimes accompanies such a dreaded diagnosis. My sister went with me to the initial appointment. Thank goodness, because after the word chemotherapy, I heard nothing else. She took notes, asked questions I couldn't ask, and later explained it all. I could have had reconstructive surgery, but that meant 6 weeks delay on the chemo, and fear said, don't wait. A side note here, my biggest regret is not having reconstructive surgery. My husband has given me total affirmation, but it's an ongoing personal regret. In my mind, chemo meant horrible sickness, vomiting, and so forth. It meant living as a bald-headed woman, embarrassment. Over the next few days, my mind adjusted and I began to think, we can do this. I say we because it affected many people besides just me. I called my principal at school to explain I would not be back that semester, and he arranged for my class. Family and friends were so supportive. I had my first chemo treatment in a room with a TV, a recliner, videos with soft, soothing music or comedy, whatever I needed. I waited all afternoon and all night for this violent illness. It didn't happen. I waited the next day and it didn't happen. Then a port was installed just under my collarbone to make chemo treatments simpler and less stressful. Within a short time, my hair began to fall out by the fistfuls. My sweet husband laughed with me and cried with me. Finally, he just gave me a buzz cut. Luckily, my daughters had helped me select a wig in advance, and the Cancer Society offered through Look Good, Feel Better support groups, wigs and cosmetic tips. I took a couple more treatments with few ill effects except baldness and some exhaustion, then called my principal to say I was ready to come back to work. Yes, I was exhausted, but so was every other teacher with whom I had worked. I completed my months of treatment, wore my wig for the last time at our daughter's wedding, and the next morning I was sporting the prettiest post-chemo hair, silver, very short, very curly, one of my rewards for surviving cancer. That was over 20 years ago. Then just recently, we had that, oh no, here we go again moment. A rather advanced skin cancer on my face. It was frightening. It was deep, but again, I received treatment and it healed. Now my biggest concern is wrinkles. Please allow me a few takeaways from this. First, for the possibility of any major issue, take someone with you who can listen, take notes, and later explain. Second, only listen to people who have real knowledge. Like childbirth, the stories range from piece of cake to horrendous. Every experience is different. Don't be consumed by fear. Third, I regret not having reconstructive surgery. It's a personal choice, but one to consider very carefully. Fourth, there are resources galore, friends and family who want to help. This illness and recovery will affect everyone close to you. Seek out and accept help. You're not in this alone. And last, and maybe the most important, you have far more strength than you realize. Use it. Thank you.
Oh, Joyce, that was wonderful. I am so glad you persisted a long time before you came here, and you get tonight in order to be able to get into the program and present for us. That was really lovely. So Joyce,
Thank you.
the meeting tonight is recorded, and so we will be able to share this with people who aren't able to attend tonight, and I'm just grateful, very grateful. Let me ask if there's some notes popping up on the screen in the chat. I don't know if you can see them. Amazing. So happy you've been able to share your story with us. Thank you for sharing your story with us, Joyce. Maybe because I think I'm looking at my clock, and I know that Liz got interrupted and isn't finished, but if we could, just to see if anybody else has any questions or comments that they want to add in response to Joyce. But I think I'm speaking for everybody that was moving, inspiring, and helpful.
Thank you.
Thank you so much. So it may be
Now,
that
what
the
do I
comments
need
in the
to do?
chat are reflecting. Pardon? You're welcome to stay and to hear the rest of Liz Winkler's presentation. Liz is an advanced practice nurse from Vanderbilt, and she was talking about survivorship care. So you are welcome to stay and listen to the rest of the presentation, or if you prefer to leave, you're free to do that, but you've really given us a very big gift, and I really appreciate you hanging in there.
Well, thank you for asking.
All right. Thank you, Joyce.
Mhm.
It was a good, smart move on my part.
Yeah, do it.
All right. You could turn off your camera if you like, or not. It's really up to you. There we go. And Liz, if you want to come back in and share your screen and continue where you were, that will be great.
Okay, I'm back. of course, Joyce, thank you for sharing your story. Every story I hear, I feel like makes me a better advocate for patients by just taking your story forward to other patients, and it affects how I do my job every day. So thank you for sharing. But meanwhile, back at the ranch, here's what I'm working on tonight. And this is what one of my care plans from the survivorship clinic would look like. When you come to see me, this is what the information I brought together for you. Now, one thing I didn't mention when I started is I do have this in a Word document that I can share with Rebecca if you're ever interested in making your own care plan. This is the way we like to lay them out. But anyway, where I kind of left off is after just getting the basics of your history put together, we're already looking at through your records to see what we think may have been related to your cancer treatment. And in this case, in this patient, I found that she's already shown signs of lymphedema. And so we're going to focus on in our appointment, in our survivorship appointment, we're going to focus in on either doing an assessment. Well, we will do an assessment for lymphedema. We will see what resources that she's been tapped into, what referrals need to be made, compression garments, anything that we can think of. We're going to kind of zero in on that. We also know that she is experiencing some peripheral neuropathy that we can relate to her Taxol treatment. And then we can just by exploring with her what the extent of her symptoms, how we can then zero in on treatment if needed, or how we can address that. And then we, based on the treatment she had with her radiation, her chemotherapy, we look at what long-term effects that she hasn't experienced, but we're going to monitor for, what we want her to monitor for. And as I said, this is also shared with her oncology care team and her primary care, so that we all know what we're looking for and what we hope to do. Now, I'm not going to go into the first part where we talk about health maintenance. I did that quite a bit in the last in our last town hall that I spoke in December, and it's important, but we're going to move on because I learned my lesson.
Liz,
Yeah.
Liz, could I just ask you to explain, because you've just used a couple of terms that I think, now you did explain what peripheral neuropathy is, but lymphedema, I wondered if you would take a minute to explain that.
Sure. This lymphedema can occur after lymph nodes have been removed, and it's just a kind of a phenomena where, because those lymph nodes have been removed, the actual lymph system is not draining appropriately, and you may see swelling in the extremity, most commonly in breast cancer, because axillary, or those nodes under the arm, have been removed, and that impacts how the drainage of the lymph occurs, and then you may get swelling in the extremities, and it can be profound. And in the past, many breast cancer patients lived with this, and since the advent of sentinel node biopsy, where they can identify the nodes that need to be removed in the surgery, that's become much less of a problem with breast cancer, but it still can be a problem. It's most commonly occurs after lymph nodes have been recurred, and it doesn't always occur just with breast cancer. I have a very large prostate cancer population and bladder cancer population, and a lot of those pelvic lymph nodes are removed as well. So it can also be abdominal swelling, or it can affect the legs. It always isn't just a profound swelling either. It can't often the questions I will ask are, how does your skin feel? And often kind of a classic answer is, I feel like my skin's too tight. So those are some of those early signs that we work with and make referrals to lymphedema clinics for treatment. So that's just a kind of a brief explanation of lymphedema. Peripheral neuropathy, that's that pins and needles that you get like your legs asleep. There are certain chemotherapies, many chemotherapies that cause it, but in this patient's protocol, it was Taxol. And it's kind of important that we cover this because those pins and needles and peripheral neuropathy occurs in other diseases as well. So we spend a lot of time on peripheral neuropathy if it exists, because it should not occur if after, like say it starts 6 months later after you finished your chemotherapy. That's not likely the cause. So we do a lot of assessment with peripheral neuropathy as well. All right, and again, I'm trying to simplify this because this is my 1 hour. This is the basis of my 1 hour appointment at the survivorship clinic. So we do cover all health maintenance of annual physical exams, what those cancer screenings are, importance of ways that you can reduce your risk of recurrence. And then in this case, dental health is also something that we have to address because systemic chemotherapy can affect our dental health as well. So we give the recommendations, and they're very similar to what the American Dental Association already recommends: brushing, flossing, biannual cleanings and x-rays, etc. But it's also very important, and that should be inform, not improve. Inform your dentist of history of chemotherapy and exposure to head or neck radiation. Then anxiety, depression, that's very common, fear of recurrence. In this case, I'm going to focus in on this because this would be a elevated cholesterol in heart problems would be a direct threat from the doxorubicin or the anthracycline. So that's why we want to look at those chemotherapy doses. And in anthracyclines, and this, if you had breast cancer, if you had chemotherapy, or you've had chemotherapies, this is known as the red devil. So this red devil can be hard on the heart. So we need to monitor how much a patient gets. But this can, over time, put you at risk for an elevated cholesterol. So we have recommendations for that. And then, of course, how to manage cancer-related fatigue. And this is very prevalent in cancer survivors. And then I'm just going to focus a little more on the heart problems. Our recommendation follows the NCC guidelines, which is that National Cancer Coalition Network guidelines. If you have had more than 250 milligrams of anthracycline in your therapy, we're going to repeat an echo, or if you have even one cardiovascular risk. And then we talk about the other ways to control a cardiovascular risk. And then memory, this is pretty prevalent thing that we monitor for in all of our patients that not only receive chemotherapy, but also radiation and even surgery, because it is multifactorial, playing into bringing in stress, depression, anxiety of a new diagnosis, as well as probably effects of the treatment itself. So that's something that we watch very closely for. And of course, in survivorship, we always want to be monitoring for the recurrence. This patient is a breast cancer patient, so our recommendations is annual mammogram is not performed on if you've had a total mastectomy. If you've had a lumpectomy, then you should continue mammograms, and you should continue your breast exam, monthly breast exams, and have biannual, twice a year, clinical breast exams by one of your care providers. So that's kind of the things we put. I could go on about this: osteoporosis, etc., pain, sexual dysfunction, and we're going to look for secondary leukemias. But that's kind of what our care plan looks like. And like I said, I have kind of a PDF, a Word document that I'll share with Rebecca if anyone's interested in kind of putting your information together. But now I want to focus here on my going to the internet here. Whoops, I might have just missed that. Or where is it? Okay, here we go. Now, can you see my Oncolink? I just did it again. Well, Liz, you're better than this. There we go. All right. Now, can you see this? I'm on the internet now in Oncolink. This is where I feel like this is where you can help yourself doing my job by making your own care plan.
I do not see it, Liz. I
All
do
right,
not
let me
on your
see.
screen.
Well,
I see your
I'm going to try and
document folder, and I still, it may be that I think you need to change your share screen. You need
Yeah.
to unshare because you're still showing us your treatment plan. So if you
Okay.
unshare that and then share again, your internet connection, then I think
Okay.
you'll see it.
let me see what else I can close here. I'm going to close up other things here. All right, now let's see here. Share screen. Ah, here we go. Is that better? Can you see it now, Rebecca?
Yes.
Okay. This is one of my
Yes.
favorite sites, everybody. This is one of my favorite sites where I get a lot of my information on long-term effects from cancer treatment. So Oncolink, and this is a great resource for patient. And we're gonna sort of make us a care plan for this patient here. So if you go to Oncolink, they have this wonderful education planning resource, create a survivorship care plan. So I'm going to open that up. And as a patient, you can do this too. We're going to develop a cancer survivorship care plan. And you win a patient's version. See how easy this is? Y'all don't even need me. You don't need to come to the clinic. You just need a computer. This is a female. And she was 42 when she was diagnosed. And now she's 44. And this is self, because this is a patient care plan. I want to create treatment summary. That's what we're going to go. Is this patient in menopause, meaning 12 months more or 12 months or more without a period? Yes, very common after breast cancer treatment to go into menopause earlier. Many cancer treatments will do that. But we're going with Tennessee here. Sorry, I meant to have all this demographic done, but at least you can see what you're going to be expected of. This patient had breast cancer. And then just things like defining what your situation is. And they're going to ask things about tobacco and smoking cessation. As I said, a big part of survivorship is wellness. So I'm a smoker. I am not, but I'm going to put it in there just so you can see it. And genetic risk in counseling, something significant for breast cancer patients. And this is where those surgeries that I've been telling you about come into play. And I know that she had lymph nodes removed. She had a mastectomy and a sentinel node biopsy. Okay. And this is the chemotherapy. She had Cytoxan. She had doxorubicin. And she had Taxol. Okay. And she had no hormone therapy, but because I just want you to see it a little bit, I'm gonna put in tamoxifen because these have some long-term effects as well. Fortunately we do not do stem cell transplant on breast cancer survivors anymore. And she didn't have radiation, but I'm gonna pull it in just so we can see where we go with that. And she had radiation after mastectomy. and no other treatments. And this is where I really think this is an important effect, because this is where you're going to get good feedback on the side effects you're having. So I'm going to kind of quickly go through this. Vaginal dryness, painful intercourse, very common after these therapies. I'm going to say no on the bladder, because I can tell, because I know what these questions are, why they're asking it. And the dose of Cytoxin is not high enough. So I'm not going to even pretend that we had that. Okay. Osteoporosis, she's on tamoxifen, known long-term effect. No to bladder cancer. And then I know that they're going to start asking a lot of questions about heart, because I generated that through saying that we had the anthracycline. So no heart attack. I'm going to say no heart failure. But cardiomyopathy is one of those effects that we anticipate with anthracyclines or the doxorubicin. And I don't know if I've got a heart arrhythmia. Ventricular dysfunction. This is another one that we really watch for, so I might as well say yes. No liver disease. And the reason why they're asking about acute myeloid leukemias, anthracyclines, or myelodysplasia are known. This is a known side effect of receiving those. So we'll just say yes. And this is that peripheral neuropathy question we were talking about. So I'm going to say yes, because I know she had it. And as she experienced weight gain, sure. And we're going to say she's still on it, because many women will stay on it for up to 10 years. We're just going to skip over some of this. Fatigue, yes. So now I'm going quickly through this, but I think it's very helpful to mindfully consider this, because you're going to get good feedback from it. Now, when they're asking me about lung fibrosis, pneumocystis, that's because of the radiation. They're already anticipating and looking for side effects from radiation, but we're going to say no. Arthritis, anything in any bone that is in the a radiation field can be affected by arthritis. Anything in the radiation field is also subject to potential secondary cancers. And we're just going to say, yes, it's pretty common to have some changes in the skin texture. I'm just going to start answering this, because this could go on. We're going to get a little information about lymphedema. Skin cancer is also very prevalent in those in the radiation fields. Secondary cancer. Okay, now we get our report. So we've given them her history. We've given them our symptoms. Now they're going to do they're going to do my job for me. You don't have to come to the clinic. The only advantage really I have, and see, I'm giving away all my secrets here. I'm selling out the survivorship sisterhood of nurse practitioners here by doing this, but I want you to have this information. Of course, the advantage of coming to our clinic is that if you do have these symptoms and you require referrals for care, that is the one thing we do. So I don't want you to think I'm too lazy. All right. So you're going to get, first of all, a summary of what your treatments were, what you've had done. It's going to give you a follow-up. And in this case for breast cancer, but it's going to give you those recommendations that I gave you on that 4-page sheet of the things about mammograms. It's already in there. You can read that. When you need mammograms, who needs MRIs, when you need to get your mammograms, when to do those clinical breast exams, when to do self-exams, because the tamoxifen is going to talk about your gynecological exams, because tamoxifen increases the risk of uterine cancer. So while you're on that drug, that's something to consider. So it's going to tell you what to do as far as to follow up what you should expect to do. It's also going to tell you some of the things to look for. When we talked about lymphedema a little bit before with the sentinel lobe biopsy, it's given us things to look for. This is early signs of lymphedema. So you can be gauging and doing your own assessment that I would be doing in the survivorship clinic. It's also going to talk to you about things ways you can avoid or prevent lymphedema from occurring. And again, with the lymph node removal that we all had, that's kind of repetitive there. And then we're looking at different ways to care for the mastectomy sites. And some of the risk of radiation. And these risks I'm going to kind of just hurry through because they're just risk of cancers, and because of the dose, this is why it's important to know the dose. For in this case, this patient did have cyclophosphamide, but you don't really have that risk of the bladder cancer that it's talking about until you have greater than 3 grams per meter square. This patient, as I said, had 2,400 milligrams per meter square. So I'm much less concerned about breast cancer in this, or excuse me, bladder cancer in this patient. And again, the anthracycline dose, as I said, there is an upper limit to the amount of this drug that a person can receive in their lifetime because of the risk to the heart. So heart health, very important. Again, I learned my lesson last time. I'm not going to read this to you. I just want to give you the idea of the information that you can get without leaving your home to come to Vanderbilt to see us. Again, more information about peripheral neuropathy, and that's from her Taxol. And then the risk of osteoporosis, and that comes from, of course, as I said, tamoxifen increases that risk. It's also increased by early menopause and women who have their cancer treatment prior to menopause. So that increases the risk too. Ways to prevent it by getting in adequate calcium, weight-bearing exercises. It gives you all of those wellness education that I'd be providing. And then skin changes with radiation, and quite a bit of information on chemo brain. And the thing about chemo brain, I know that's one thing that most women, is very popular, I should say very common after chemotherapy or after breast cancer treatment. And typically that we give it about a year before we become concerned. Usually about a year, we kind of see this kind of coming back to its baseline. But in that time, we want to just use different tools for to just kind of keep the mind strong, like doing puzzles, doing any kind of games or things on the computer are helpful, and then just coping skills. But there is hope that at a year, it does tend to get better. And of course, treating the underlying problems like depression, anxiety, fatigue also is very helpful in managing chemo brain. And side effects of tamoxifen, it's going to give us more information about sexual health and developing secondary cancers. As I said, it's secondary cancers in this patient that I'm going to worry about. First of all, is anything in her radiation field, and if she's had her left chest wall was radiated, she's going to be at a increased risk for heart disease, that type of thing. So you can find a lot of this information here on OncoLink. So then radiation, as you can see, that's going to give you a lot of information that I've already talked about, because you're going to get a repeat here, as I said, because we've got chest radiation on top of anthracycline. So that's why you're getting that information twice. You've got it once for the anthracycline. You're going to get it in the radiation section too. But again, they're cumulative. So a patient that has both of those, I often will go ahead and refer them to cardio-oncology, or at least make sure that they have a cardiology workup with someone, or that they've had a good cardiology workup. And then lung, because the lung is in the radiation field, we want to be mindful of lung health, bone health, skin. And I have many patients that have radiation that I recommend that they have annual skin exams with a dermatologist and more. Now, the rest of it is just going to be wellness information. But I love this site. I love the information you get. I wanted to give you something that you could do at home, that you didn't need to come to Vanderbilt to see me. So it's just I wanted to give you kind of a format to put your information together when you have those 2 folders full of papers, but also this is a way that you can get the teaching and the resources and the information I would be giving you in a survivorship appointment. So that's just a little information I wanted to share, Rebecca, and everyone out there.
Liz, I am delighted that you were able to bring this particular tool to my attention, and I think to a lot of other people, because as you say, it's something people can do at home. And I know I have one question about it, and we'll have time for others as well, but I wondered, how do people, what is it that someone should ask for to get the list of treatments and the time of treatments? I mean, because I'm thinking a lot of medical records, you know,
Right.
it's a lot of information. What
Mhm.
can people ask for to get what they?
This is what I always ask for, because most of my patients aren't treated at Vanderbilt, or because part of what I do for Vanderbilt is new patients that want to transfer care to Vanderbilt after they completed treatment. They may have moved from Texas, but they had cancer treatment at MD Anderson. Now they want somebody to follow them at Vanderbilt. Well, I'm kind of the gatekeeper for that. I bring their information together, and I have a very clear wish list of what I want. And that would be any and all pathology reports. And usually there are 2 pathology reports, one from the initial biopsy. And if there was a surgery done, whatever's removed, in this case, the breast removed, there's going to be another pathology report. So there's usually the report from the biopsy, there's a report from the surgery. I want operative reports. That's all I need. And just operative reports. And that's what they're universally known as. That's how I fill in those surgeries you have. Then I want chemotherapy administration records. That's going to tell me what chemotherapy you had. And from there, I can calculate the doses you've had. And that's only really important in anthracycline, or that red devil drug that I talked about. And I mentioned that as red devil because most patients, once I say red devil, they know the drug we're talking about. I want the end of treatment summary from radiation oncology. And I want to get the office notes from their medical oncologist. And those are I mean, you can get thousands of pages. There's thousands and thousands of pages of medical records.
Is there any? Right. No, I was wondering, for filling out this particular form, this OncoLife,
yeah,
is there a way a person can ask? I mean, would it be like in that treatment summary or something? You know, maybe people are keeping records all the way along, but you know, a lot of times it's so much information that it can be hard to sort it out. And I was just wondering if there was a way someone could ask a question of their medical records that would give them what they needed to fill this out. Because you know,
that's what I'm trying to, that's what I'm trying, that's what I'm trying to say. That's why I wanted to compare what I do with OncoLink, so you could see how you can get the information, because my care summary is very concise and very short compared to this. And when I share that, you can say, I want to know where treatment was done and who did it. I want the pathology reports. I want the genetic counseling and genetic testing results, because that's going to be very important going forward, how we manage cancer risk. Their chemotherapy administration records. That's how we calculate the dose, know what chemotherapies that we had, so we know what long-term effects to look for. And there's only one thing I want from a radiation oncologist, and it's called everywhere universally. It's known as the end of treatment summary for radiation oncology. So that's how I fill all that in operative reports. That's how I fill out my care plan, and then I build it from there, knowing what treatment they've had and what can occur over the course of their life at that point.
Well, it sounds like your care summary is a very useful document.
Well, I build them before I have my first meeting, because that's, like I said, many survivorship clinics and publications refer to it as a roadmap for your future. Well, I kind of see it as you come to a fork in the road and you want to go down the road that's going to lead to wellness. And this is how we try to direct your future towards wellness. When you read from OncoLink or you spend time with me, you're going to learn about how to reduce your risk of cancer recurrence. And you can get all that information right here on OncoLink.
All right. Well, let's see if there are others who have questions. We're getting close to where we need to wrap up, but we have time.
Oh my
for
gosh, yeah.
a couple of questions. If there's anybody else who wants to ask Liz a question, while we have an obvious expert in cancer survivorship in our town hall this evening. And I definitely want to say thank you again, Liz, for a massive amount of information that you presented in a way that I find it very well organized. It helps me to feel
I can
organized.
go on forever on these topics. I'm kind of passionate about it, as you can tell. So sometimes I overwhelm. So I'm trying to just, hopefully this will be something that you can all use.
So we'll see if we have, yeah, so we have in chat, this has been very informative and useful. And boy, I would agree. I'm thinking, I have a friend who is helping a friend of hers who is currently going through, I believe it might be liver cancer. And I'm going to recommend to my friend that she watch this recording, because I know my friend is very interested in being a support to her friend.
Mm-hmm.
And I think you've presented in a pretty concise way a lot of information that she can use. So,
I think I told you an email
Yeah.
earlier that my laptop failed and I'm using a computer that belongs to my son, so I'm short on my resources, but I actually have a PDF where you can share, where you can actually go in and edit these boxes and put your information into it and make it your own. Just take all those
Oh,
pages that you have
okay.
and make it your own.
Well, you were kind enough to share your email address with us back in December, so we'll make sure that that's on our Cancer Survivors Alliance website, along with this link to this recorded information. And again, really thank you. I wonder, Liz, let's see if, yes, I'm going to share my screen just briefly. Let me see here. So I mentioned before that the Cancer Survivors Alliance is offering a program called Cancer Thriving and Surviving. And many of the concerns that you described are ones that are addressed in this course, and these are the topics that are addressed. And so, as I mentioned, we're looking to find 8 to 12 people who would be interested in participating in a group like this. And once we get that number, we will set up a way for people to join us, either in person or in a virtual group. And it's a 6-week course and it's free. And Anita Icorn and I will be the leaders for this group. It's a way for people to come together and support each other and share useful information. And in addition, we have this curriculum that has been very helpful to people around the world. And I have just a few other things to remind people about our survey. We're hoping that people will spread the word about this survey. The Department of Health estimates that we might have as many as 2,000 cancer survivors in Cheatham County, people who've been diagnosed within the last 5 years. And we would like very much to get input from them, excuse me, about what kinds of experiences they've had, what they found helpful, and what they need. And thanks again very much to Joyce for coming in with her very inspiring talk, and Liz, thanks to you. And these are some key takeaways that I want to pull from the talk that we've had. The cancer survivorship, according to our definition in the Alliance, it begins at the time of diagnosis. So we are supporters of people from the very beginning until as long as they want us to be able to help them. And the Alliance was formed to improve quality of life and health outcomes in Cheatham County. We're a brand new organization. We have lots of room to grow, and we could use a lot of help. And our webpage offers a lot of resources. Right now on our webpage, you'll see information about mobile mammography. St. Thomas Hospital is bringing to Delivery Stable in Pleasant View in April. And that's a really nice service. I hear that it's very comfortable accommodations. And so there's information about that on our webpage. There's information about Pink Out for Hope, which is an organization that has been in Cheatham County for a long time. And we are very proud to be a supporter of their work for breast cancer survivors. So we hope you'll look at our website and see information about virtual resources that are available to people currently. So I think we have a post-test. It's not really a test, really. It's an evaluation to help us evaluate how clear we are in our messaging. Thank you very much, Monica. So here is a short survey to tell us what you are feeling, thinking at the end of this program. Some of the same questions that we presented at the beginning to see, obviously, we want to see if there's been any change in the way people answer them. All righty, thank you for putting that up. Very good. Okay, and as you might expect with anything like this town hall, there are a lot of people to thank for putting it together. I want to acknowledge Ashley Bridgman, who created our logo that we're so happy to have on a mask that we give away to people when they participate in our survey. We can give it to people who participate in the community education programs. Ashley Kleinert is with the health department. She is a health educator who has been a supporter of our work. Liz Drake is a survivor, as is Paula Lee, who've both given us a lot of time and advice. Anita, many of you know from the Extension Service. Amber was our first Austin Peay State University intern. She worked with us last December, and she then has joined the coalition as a member of our staff, and she's been here tonight helping us out. John Patrick has been one of the people who's already presented one of our community education programs, and Kristen Wright is our staff person. All of the people who are on this list are volunteers. They have all volunteered, even those who are staff for the coalition. They have other jobs, and what they do for this alliance is volunteer, and we are very grateful for their skill and their care and their attention to details to make things happen like this town hall. So Kristen is a staff member, and she is a supervisor of the interns who are working with us. And we are very fortunate to have Mar Alice and Monica Oakley, who are Austin Peay State University social work students. And thank you both for being part of this team and for helping set up tonight's meeting and many other things that you're doing. And we have still just a few minutes if anybody else has any other comments or questions. We are really eager to get feedback from the community to help us grow this alliance. And I'm not sure if there's anything in the chat. No, I'm not seeing anything. So Liz, I want to thank you again for opening my eyes, and I think maybe others as well, to this web-based tool that can be used to help organize a very complex amount of information. And then as you showed us, it generates very practical advice. And I put a kind of a plug in there for our Cancer Thriving and Surviving program. When you showed scrolled through it, you know, there are a lot of ways in which this program is designed to address some of those kinds of issues that might come up for people after treatment for cancer. So thank you again for being with us.
Oh, my pleasure. My pleasure. I didn't even have to put shoes on to come.
Yeah. That is one advantage of these virtual meetings. We can all just, we don't have to drive anywhere. We're all home, most of us. I hope everybody's home and can just say goodnight and move on to whatever is next on your agenda. I would like to acknowledge Rochelle Roberts and Amy Chart, who are joining us tonight. Thank you very much. They are from the Tennessee Department of Health. They are the team that has guided us tremendously on many different steps of this project and have given us encouragement. And so in addition to you know, being part of the group that approved the funding for this project, I think we've learned a lot. And I really appreciate, Amy and Michelle, that you joined us tonight and are giving us support in this way as well. And I hope I've thanked everybody in the room. I know that there are more people that help than are in the room, but thank you all. All right. So I wish you all a good night, and thank you again for joining us. Thank you, Monica, for managing the Zoom. Bye-bye.